Hatch score for prediction of atrial fibrillation. Hatch score was developed for prediction of progression from paroxysmal to persistent atrial fibrillation. It checks the following parameters: heart failure, age, previous transient ischemic attack or stroke, chronic obstructive pulmonary disease, and hypertension. For the analysis, the authors included 1,219 patients with paroxysmal AF who participated in Euro Heart Survey on AF. Those who had progression of AF after 1 year of follow-up were noted. The components and weightage given in Hatch score were as follows: hypertension 1, age 75 years or more 1, transient ischemic attack or stroke 2, chronic obstructive pulmonary disease 1, heart failure 2. In their study, 15% had progression of atrial fibrillation. It was noted that 50% of those with a score more than 5 progressed to persistent AF, while only 6% of those with score of 0 progressed. Those with progression of AF had more hospitalizations. They also had more major cardiovascular events. Hatch score was used by Sunari and Associates to predict new onset atrial fibrillation using Taiwan National Health Insurance Research Database. Over a 2-year period spanning from January 1, 2000 to December 31, 2001, they enrolled 670,804 patients older than 20 years who had no history of cardiac arrhythmias. Huge majority of patients had Hatch score of 0. 1.4% of patients had new onset atrial fibrillation during a mean follow-up period of 9 years. The occurrence of new onset atrial fibrillation was 0.8 per 1000 patient years at Hatch score 0, while it was 57.3 per 1000 patient years with the Hatch score of 7. Chen and colleagues used the Hatch score to predict the occurrence of new onset AF after catheter ablation of typical atrial flutter. Of the 216 patients in their study, 39% experienced at least one episode of AF over a mean follow-up of 29.1 months. Using a cutoff score of 2, the group could be stratified into high-risk group with 69% occurrence of AF versus a lower risk group with 27% occurrence of AF. Here are some important journal references on Hatch score. Anticoagulation for prevention of stroke is a well-established modality of treatment in atrial fibrillation, but a significant number of them have bleeding complications. Hence, the option of left atrial appendage closure with multiple types of devices have been developed. Left atrial appendage with its sluggish flow is the most common location for thrombus formation in atrial fibrillation. Following devices have been used with varying success: 1. Watchman, 2. Amblatzer cardiac plug or amulet, 3. Lariat suture ligation, 4. AtriClip. Protect AF studying Watchman device randomized patients with non-valvular AF if they had at least one of stroke or transient ischemic attack, congestive heart failure, diabetes, hypertension, or age 75 years or more. This was a multi-center non-inferiority trial. Warfarin was eventually discontinued in the intervention group, while it was continued with target INR 2 to 3 in the control group. Initial results showed non-inferiority with higher primary safety events in the intervention group. 2.3-year follow-up data was reported later was also similar. Warfarin was continued for about 45 days after device implantation, followed by clopidogrel for 4.5 months and lifelong aspirin. Amblatzer cardiac plug bar amulet real-world registry included 1,088 patients. Of these patients with non-valvular AF, 82.8% had an absolute or relative contraindication to long-term anticoagulation, while 72.4% had a previous major bleeding episode. Device could be successfully implanted in 99% of cases. Lariat suture ligation requires both endocardial transeptal and epicardial access. Pilari and Associates have shown lower leaks at 1 year with Lariat compared to Watchman, with no difference in the rates of cerebrovascular accidents. As the lariat electrically isolates the left atrial appendage, it may also reduce the AF burden. AtriClip is an epicardial surgical closure device which can be used in both open and minimally invasive approaches. It has been shown to reduce the risk of stroke in those undergoing cardiac surgery when the device was deployed epicardially during open heart surgery. Here are the initial set of references on left atrial appendage closure devices. Here are a few more references. Discussion on P2 CHA2DS2-VASc score for prediction of stroke risk in atrial fibrillation. P2 CHA2DS2-VASc score adds additional 2 points to the CHA2DS2-VASc score for an abnormal P-wave axis to predict risk of stroke in atrial fibrillation. The seminal study was an attempt to identify utility of P-wave indices in sinus rhythm to predict the risk of stroke over and above the existing CHA2DS2-VASc score. P-wave indices evaluated were prolonged P-wave duration, abnormal P-wave axis, advanced interatrial block, and abnormal P-wave terminal force in lead V1. They found that abnormal P-wave axis, which is an ECG correlate of left atrial abnormality, improves the prediction of ischemic stroke. They concluded that P2 CHA2DS2-VASc score is a better prediction tool for AF-related ischemic stroke than CHA2DS2-VASc score. Scoring in P2 CHA2DS2-VASc gives 2 points for abnormal P-wave axis, 1 point for age between 65 to 74 years, and 2 points for age 75 or more, 1 point each for female sex, heart failure, hypertension, diabetes mellitus, and previous myocardial infarction or peripheral arterial disease, and 2 points for prevalent stroke or transient ischemic attack. The study used data from 2 large community-based prospective cohort studies for prediction of atrial fibrillation-related stroke. The hypothesis was tested in the ARIC data and validated in the MESA data. References for ARIC and MESA studies. In the study used for deriving P2 CHA2DS2-VASc score, advanced interatrial block was also independently associated with AF-related stroke, but it did not improve risk prediction in their models, which they thought could be due to low prevalence in their population. Fibrotic atrial remodeling and enlargement have been considered as important components of pro-arrhythmic and prothrombotic substrates in the development of AF and AF-related stroke. P-wave indices are surrogates for detection of this substrate on the ECG. P2 CHA2DS2-VASc score was developed as several analyses of large databases have noted the limitations of CHA2DS2-VASc score. It was thought that limitations of CHA2DS2-VASc score may be because it measures only atherosclerotic risk factors and does not directly reflect mechanisms of AF-related thromboembolism. CHA2DS2 and CHA2DS2-VASc have been used to predict risk of stroke or TIA in patients discharged after acute coronary syndrome without known AF. Accuracy was similar to that observed in historical populations with non-valvular AF and lower absolute event rates. Stroke prediction by the CHA2DS2-VASc score in people without AF but with abnormal P-wave indices was comparable to people with atrial fibrillation. In other words, P2 CHA2DS2-VASc score might be useful to predict stroke in persons without AF but needs validation in further studies. P2 CHA2DS2-VASc score cannot be used in patients with persistent or permanent AF who have no ECGs in sinus rhythm because P-wave axis cannot be calculated in the presence of AF. Discussion on postoperative AF after cardiac surgery. Postoperative AF is one of the most common complications after cardiac surgery. The occurrence of postoperative AF is rising as more and more older patients are undergoing cardiac surgery. It may occur in up to 1/3 of post-cardiac surgical patients. Several trials have evaluated postoperative AF and many meta-analyses have been conducted on these trials. AF can occur both after coronary artery bypass graft surgery and surgery for valvular heart disease. The onset of AF would mean longer stay in the intensive care unit and higher risk of postoperative stroke. The risk of stroke is enhanced 2 to 4 times with postoperative AF. In addition, there is a chance for delirium and cognitive dysfunction in these cases. Postoperative AF after coronary artery bypass graft surgery has been associated with both higher in-hospital and long-term mortality. The study compared 994 patients who developed post-CABG AF and 5,481 who did not develop AF. Survival at 5 years was 87% in those who had postoperative AF, while it was 93% in those who did not have AF. Several strategies have been employed in the prevention and treatment of postoperative AF. They include beta blockers, magnesium, sotalol, amiodarone, calcium channel blockers, digoxin, and atrial overdrive pacing. Of the lot, digoxin appears to have least evidence in favor of it. Use of digoxin for prophylaxis against AF is a class 3 recommendation as per 2014 AATS guidelines, that is, not to be used for prophylaxis. Beta blocker withdrawal may increase the risk of postoperative AF. Continuation of beta blockers is a class 1 recommendation in 2014 AATS guidelines. Sotalol appears to be more effective than conventional beta blockers in some studies. Various forms of atrial pacing used in the prevention of postoperative AF are right atrial pacing, biatrial pacing, left atrial pacing, and Bachmann's bundle pacing. Several trials have evaluated the role of pacing, but the overall results have not been very encouraging, though there was mild reduction in the incidence of postoperative AF. Amiodarone has been evaluated in several trials with fair results. 2014 AATS guidelines gave a class 2A recommendation for the use of amiodarone in postoperative AF. They advise caution while selecting doses for intravenous or oral route because cases of ARDS had been reported following pneumonectomy with cumulative intravenous doses above 2150 milligrams. Emergency synchronized cardioversion is needed in postoperative AF with hemodynamic instability. That is a class 1 recommendation. Beta blockers and non-dihydropyridine calcium channel blockers like diltiazem have a class 1 indication for rate control in postoperative AF. Caution is advised in those with left ventricular dysfunction, heart failure, or hypotension. Intravenous amiodarone has a class 2A recommendation in these situations. Amiodarone has a potential for converting AF to sinus rhythm. Hence, if it is initiated after 48 hours of onset of AF, transesophageal echo to rule out left atrial or appendage thrombi and anticoagulation are to be considered if feasible. Here are the first set of references. Second set of references are here. There are several reversible or transient factors which can lead on to atrial fibrillation. Many of these episodes of atrial fibrillation may be self-limited or disappear after the cause is taken care of. Acute alcoholic binge is an important cause of transient atrial fibrillation. Atrial fibrillation in this setting is known as holiday heart syndrome. Though reversible, it can recur in the next binge. Cardiac surgery, both coronary and valvular, are known to be transient causes of atrial fibrillation. It is more likely in valvular surgery. Atrial fibrillation in this setting can increase stay in the intensive care unit, morbidity, and cost of care. Myocardial infarction is another important cause of transient atrial fibrillation. It may be an indicator of atrial infarction. AF in myocardial infarction can be due to atrial stretch in left ventricular dysfunction. Atrial fibrillation is also the commonest sustained arrhythmia following non-cardiac surgery. Perioperative sympathetic surge, electrolyte imbalances, and use of supports are important factors to be considered. Acute myocarditis and pericarditis can cause transient atrial fibrillation. Inflammation of atrial pericardium and myocardium and atrial stretch due to left ventricular dysfunction have to be thought of. Atrial fibrillation in acute pulmonary embolism can be due to atrial stretch as well as due to the hyperadrenergic state. Atrial fibrillation is a well-known association of hyperthyroidism. It was thought that there is a higher chance of thromboembolism in this scenario, though the evidence is not conclusive. Electrocution can cause both atrial fibrillation and ventricular fibrillation. This occurs when the shock falls in the vulnerable phase of repolarization. Discussion on scores predicting bleeding risk in AF with anticoagulation. Anticoagulation is vital for reducing the risk of stroke in atrial fibrillation. There are several scores predicting bleeding risk in AF. These can be used to weigh between the need for anticoagulation and the risk of bleeding with it while taking an individualized decision. Has blood score, hypertension, abnormal liver or renal function, stroke, bleeding, labile INRs, elderly above 65 years, drugs or ethanol abuse. Drugs are antiplatelet agents or non-steroidal anti-inflammatory drugs used concomitantly. Maximum number of points possible on the Has blood score is 9. Has blood scoring is based on the Euro Heart survey involving about 4,000 subjects with atrial fibrillation. In this study, number of bleeds per 100 patient years ranged from 1.13 to 12.5 when scores increased from 0 to 5. There were only 2 patients with a score of 6 and no patient had scores above 6. While deciding on long-term oral anticoagulation, the risk of bleeding should be less than the risk due to stroke for a beneficial effect of anticoagulation to be obtained. Hemorrhages, hepatic or renal disease, ethanol abuse, malignancy history, older than age 75, reduced platelet count or function, rebleeding risk, hypertension, anemia, genetic factors, CYP2C9 single nucleotide polymorphisms, excessive fall risk, stroke history, Atria score, anemia, severe renal disease, age 75 or older, any prior hemorrhage diagnosis, hypertension history. Orbit score was based on outcomes registry for better informed treatment. It may be noted that most scores have the same variables which increased risk of stroke in the scores for recommending anticoagulation in AF. In a post hoc analysis of clinically relevant and major bleeding in the around 2,300 patients on warfarin in the Amadeus trial, Has blood score was shown to be better performing than Atria and Orbit scores. Discussion on short run of ventricular tachycardia and atrial fibrillation. Underlying rhythm is atrial fibrillation as there are no P waves and it is an irregular rhythm. Short run of wide QRS tachycardia should be considered as run of ventricular tachycardia. Alternate possibility is Ashman phenomenon and concealed transeptal conduction maintaining aberrancy. But the short run is much faster than the basic ventricular rate of the atrial fibrillation. Yet a long short sequence as in Ashman phenomenon is evident at the onset with cycle lengths of 480 and 320 milliseconds. Moreover, the cycle length of the tachycardia beats is almost constant at 320 milliseconds. Cycle lengths would have been irregular if it was Ashman phenomenon and concealed transeptal conduction. The pause of 600 milliseconds after termination of the tachycardia is also in favor of ventricular ectopic activity causing a ventricular tachycardia. The pause can be considered like a full compensatory pause which is not part of the Fish criteria for Ashman phenomenon. One possibility to be considered when a run of ventricular tachycardia occurs in the setting of atrial fibrillation is digoxin toxicity. Digoxin is still being used for control of ventricular rate in atrial fibrillation, though its use has come down much compared to yesteryears when it was the sheet anchor of treatment. One would expect some STT changes, that is reverse correction mark sign in the baseline rhythm in case of digoxin toxicity, which is not seen here. Moreover, the ventricular rate of atrial fibrillation is not that slow as we expect when toxic levels of digoxin are present. But these are not absolute criteria which can confidently rule out digoxin toxicity as a cause in this case. Other possibilities for increased myocardial irritability like electrolyte imbalance and myocardial ischemia are more likely for this type of rhythm on the monitor in the current scenario. Here are a couple of references on Ashman phenomenon and Fish criteria. Ultra-rapid delayed rectifier potassium current blockers in atrial fibrillation. Suppression of atrial fibrillation with drugs has always been a difficult issue. Most agents which suppress atrial fibrillation have certain problems like proarrhythmia or extracardiac side effects. A novel strategy which has been proposed is the development of agents which act preferentially on the atria rather than on the ventricles. The ultra-rapid delayed rectifier potassium current is expressed in the atria but not in the ventricles. Inhibition of IKUR has been considered as an atrial selective antiarrhythmic treatment. Vernakalant inhibits IKUR and IKACH at low concentration. These are atrial specific potassium channels. At higher concentrations, it can block ITO and INA also. Vernakalant is a rapidly acting drug useful in the treatment of recent onset atrial fibrillation. Atrial selective sodium channel blockade with drugs like ranolazine is another approach which has been evaluated. KV 1.5 channels are responsible for the IKUR and KV 1.5 channels are encoded by the gene KCNA5. Some concern has been raised because IKUR block may abbreviate atrial repolarization and loss of function mutations in KCNA5 has been associated with familial atrial fibrillation. Unlike amiodarone, which is a slow-acting drug, Vernakalant is a rapidly acting medication. Both intravenous and oral preparations have been tried. Side effects listed include bad taste, paresthesia, sneezing, nausea, and rarely hypotension and very rarely ventricular arrhythmias. Long-term studies documenting efficacy and safety may be needed further. 2016 European Society of Cardiology guidelines for the management of atrial fibrillation gave class 1 level A recommendation for pharmacological cardioversion of AF with no history of ischemic heart disease or structural heart disease. In those with stable ischemic heart disease or moderate heart failure or abnormal LVH, it is class 2B level B. Thank you for watching this video. Please subscribe, like, share and post your valuable comment below this video. Kindly press the bell icon after that for getting all updates.